Marilyn, thanks so much. It's a real honor and privilege to be here, and thank you, David Foster, for inviting me. I mean, the work that you guys are doing is just absolutely fantastic. I'm going to do something that I have never done before at a talk. I was Billy's physician for a while, as you know, and since that time, I've treated a great many patients with this disease, and unfortunately the harsh reality is that we still don't cure an awful lot of people. So I'd like to take just a few moments of silence really to remember Billy and all of the other patients that I've treated, and maybe you guys can think of patients who you've known with this disease who are still suffering or who are no longer with us. So as Marilyn said, I'm a surgeon at MD Anderson, a thoracic surgeon, and really have been specializing in the treatment of malignant mesothelioma of the chest, pleural cavity, for over 8 years now. And it's something that I've gotten quite passionate about, and unfortunately, it is one of those diseases that remains exceedingly challenging for surgeons. And some of the reasons you can see here in this picture, oftentimes by the time patients actually end up in my clinic, they're at a point where the disease is actually quite extensive, and unlike lung cancer, where usually the tumor involves just one small area of the lung that can be easily cut out, the tumor, as you can see from the slide, really involves all of the surface of the lung. It really sort of wraps itself around the lung, very much like the peel of an orange. It's a frustrating disease from the medical standpoint to treat, as well as for patients, obviously, because it doesn't respond well to chemotherapy. Radiation on its own is typically ineffective. It can be effective when we give it after surgery, and we'll talk about that in a little bit. The surgery itself for this disease is about one of the hardest surgeries and most extensive surgeries that you can do on a patient. And I'm going to talk today mainly about the two types of surgery that we do for malignant mesothelioma. Both are what we call cytoreductive surgery, meaning we want to reduce the amount of tumor burden in the chest. Extrapleural pneumonectomy and pleurectomy decortication are those two surgeries. We'll talk much more about those in the future. Despite treating this aggressively with surgery, despite giving radiation, despite giving chemotherapy, unfortunately, the vast majority of the time, this tumor still comes back. And unfortunately, even today in 2009, despite all of the research that's gone into this, it most of the time ends up being a fatal disease. This was an interesting article that I pulled up. So this was actually a review of malignant mesothelioma published over 20 years ago. And it just shows the nihilism that has existed. And the title is Malignant Pleural Mesothelioma, a disease unaffected by current therapeutic maneuvers. Unfortunately, you could probably still write that article right now and get away with it. I think when we look at the literature regarding treatment for this disease, we have to bear in mind a number of factors. First of all, this is an exceedingly rare disease. It's a well-publicized disease, but there's only about 3,000 cases per year in this country. What that means is that it's very difficult to do good, randomized, prospective trials so that we get good data. So most of what we know about malignant mesothelioma comes from retrospective studies. These are studies that are performed typically on small numbers of patients from single institutions. There are differences in the reporting of how people calculate survival. Some people calculate survival from the date of diagnosis of the tumor. Some people calculate it from the date of first treatment or first surgery. There are about 7 different staging systems that have been reported. And by staging systems, we mean a system of classifying the extent of the tumor. So there is inconsistent reporting of staging. Not everybody who reports on mesothelioma breaks it down into the different histologic subtypes or cell types. As most of you know, probably there's a good cell type to have, epithelioid, but there are also bad cell types to have, the non-epithelioid tumors. And so if you don't report these in the literature, then you really have no idea whether or not somebody's reporting a better prognosis group of patients or a worse prognosis. People treat this disease differently as well, and their indications for doing surgery may be different at one center than another center. So if you report results of surgery from a center that will operate on everybody, of course they're going to be much worse than a very conservative center that cherry picks who they operate on, only operates on the good performance status patients with low volume disease. So all of these things I think we have to factor in to our reviews of the literature and what studies say. I want to spend a tiny moment here on the natural history of this disease. Typically, this is how people present with mesothelioma, a large, bulky tumor. In this particular gentleman's case, his tumor had actually started causing pain and was eroding into the side of his chest. You can see here that the tumor is involving the chest wall. It used to be thought that mesothelioma was purely a local disease, that it just involved the affected lung and the affected chest, whether it was the right chest or the left chest. We really didn't think that it spread anywhere else, but we now know that's not true. In about 70% of cases, actually, tumor, just like any other tumor, like lung cancer, pancreatic cancer, or colon cancer, tumor can get into the bloodstream or the lymphatic system and can spread to other places. This slide here shows a patient who, on initial review, had no metastases in his left lung, but subsequently developed multiple nodules in the left lung, metastatic disease. Sometimes people can present just with fluid in the chest, though, and oftentimes this is the earliest manifestation of this disease. You can clearly see a difference between this patient, all of this gray stuff in the patient's chest on the CT scan. That's all fluid. That's all pleural fluid. This is a much earlier stage of disease typically than the first slide that I showed. So there is a tremendous variation of how this disease presents initially. And that really how the disease initially presents has an awful lot to do with prognosis. The prognosis of the patient who has a bulky tumor in their chest is much worse and much shorter than a patient who had just fluid buildup, typically. This was a recent Canadian study where they looked at over 100 patients who did not receive any kind of chemotherapy. And I think this is an important study because this is a relatively recent study. This is in 2001. And they show that the median survival from the date of diagnosis of mesothelioma was only 7 months. But then compare this to a study recently published by a pulmonologist out in California, I believe, who reported a median survival of 19 months on a group of patients who he performed talc pleurodesis. Now what that means is these were a group of patients, most of which probably had early stage disease, who basically presented with fluid on their chest. And what they did was they went in and they removed that fluid and they put talcum powder inside the chest to cause the lung to stick up against the chest wall lining to prevent that fluid from building up. Those patients, even though talc has nothing to do with killing tumor cells, those patients had a median survival of 19 months. Is this because talc pleurodesis magically cured the tumor? No. This is because this is an earlier stage group of patients. So the natural history of an early stage tumor is going to be different from a more advanced stage tumor. And in fact, we know this from a study that was performed in the 70s. This was a study that looked at patients. Everybody had a thoracoscopy, which meant that we took a little camera, we looked inside their chest. Patients who had normal appearing lungs where the tumor was just confined to the chest wall had a much better survival than patients who had tumor involving their actual lungs.